everybody. Well, this is so wonderful. Thank you for the invitation to speak. And it's such a pleasure to be able to talk to everybody and share a little bit of information and advice around how to care for women seeking contraception. And in particular, we're going to talk about adolescents. I didn't realize I was going to have such a fabulous introduction, so I made an introduction slide. So in the US, we have a specialty called adolescent medicine. So I am one of those types of physicians. I work at a hospital called Nationwide Children's Hospital, and this is actually the second largest freestanding children's hospital in the United States. And I'm an associate professor of pediatrics at The Ohio State University, which is a very large public university in the United States. My training was in general pediatrics, and then a fellowship in adolescent medicine and a public health degree. My mission statement, and I keep this on my wall to keep me focused, is to improve girls' lives through partnerships to increase access to quality reproductive health care. So to that, I do a fair amount of clinical care here in Columbus, Ohio. I participate in research. I do advocacy, both at the state and national level. I lead programming to improve access to contraceptives and reproductive health care services. And then I teach our medical students, residents, fellows, and other practicing clinicians. And to frame this as a point of reference, I live in Columbus, Ohio, which is in the middle of the US. It's pretty rural area with lots of farms around. This is a fairly large city of about 1.5 million, and it's the state capital. So there you go. So now we'll get into the talk. So thanks a lot. I did want to let you know, as in terms of the disclosures, which we commonly do in the US, is that I'm a consultant and a Nexplanon clinical trainer for Merck, and I'm also a consultant for Bayer. And Merck makes the Nexplanon, and Bayer makes a variety of hormonal IUDs that you may be aware of. The objectives of the talk are to list, so that the learner can list the recommended elements of contraception counseling for adolescent patients. And number two, demonstrate how to be reasonably certain a woman is not pregnant. Here's my outline. We will talk about long-acting reversible contraceptives, and we're going to call that LARC 101. We're just going to review. We're going to talk about some common myths that we hear, and it'll be interesting to get your feedback whether these are also kind of perceptions of folks in Africa. And we will then talk about contraception counseling and resources. And I did want to share with the group that I'm involved in. For 20 years, I've been involved with an NGO that does work in Mali. So I have spent some time in West Africa, but it's been a while since I've been there. But I remain involved through our NGO called Medicine for Mali. Alrighty, here we go, LARC 101. So long-acting reversible contraception is a term that is used to describe the most highly effective reversible forms of contraception. Those include contraceptive implants, of which there are 2 currently available in the world, and we'll talk about those in detail, as well as a variety of intrauterine devices. So we will just use the term LARC at some times in this talk, and it refers to that group of contraceptives. We've gotten some feedback in the US from young people that the terminology around long-acting can be a bit off-putting, and some have suggested we use the term low-maintenance contraception to replace LARC. So I think that's interesting coming from young people. So this is a chart that many of you are probably familiar with. James Trussell has developed these typical use effectiveness or failure rate charts. And what this chart shows is the percent of users with an unintended pregnancy during the first year of use of the contraceptive methods with typical use. And what we see is that the contraceptive implants, both the Etonogestrel and Levonorgestrel, which are progestin implants, have very, very low typical use failure rates at around 0.05%. Next, in terms of effectiveness, we have the hormonal IUDs. And you can see their typical use failure rates in the first year are 0.2 to 0.9%, followed by the copper IUD. So those are the devices that we consider LARC devices. And you can see that their typical use failure rate is very, very low, and their effectiveness is very high. And I want to show you, when I'm talking with my patients, we typically kind of go down in order of effectiveness in the counseling. Depo-Provera, which I believe you have access to, the typical use failure rate is 6%. So that's a considerable drop down from the LARC methods. And then pill patch ring typical use failure rate is 9%. And the numbers suggest that the typical use failure rate is even higher for adolescent and teen users for the pill and the patch and the ring. The diaphragm is typical use failure rate of around 12%, male condom 18%, withdrawal 22%, and fertility awareness 24%. So just to highlight, the long-acting reversible contraceptives really are the most effective contraceptives available with the lowest typical use failure rates. And this is a different way of presenting that same information, showing tiers of effectiveness from works really, really well to works okay and then not so well. And again, we are framing this in the context of pregnancy prevention and how well it works. Another aspect of long-acting reversible contraceptives is that they have relatively high one-year adherence in all populations of users. And then this slide in particular shows us the adherence in 14 to 19-year-old users. And we can see that the users of the Mirena, the copper IUD, and the implant have one-year adherence more than 75% in for Mirena, and the implant more than 80%. And then conversely, if we look at Depo use, which is DMPA, oral contraceptive pill use in the teal, patch, and ring, the degree of continuation at 1 year is less than 50%. So to sum up, LARC, or I guess to also introduce, offers protection from 3 to 10 years. It's a highly effective method of birth control. It's reversible and doesn't negatively impact future fertility. It's safe. Almost all women can use them, and it's hands-free, so it requires no additional user actions. It's easy to use, and it really removes kind of the adherence problems from effectiveness. All right, so I wanted to share with you that in the US, LARC has been endorsed and recommended for use by adolescents by a variety of professional organizations, including the Centers for Disease Control, the American Academy of Pediatrics, the Society of Family Planning, and the American Congress of Obstetricians and Gynecologists really say that adolescents should be considered as candidates for LARC, and LARC are recommended as really the first line options for teens. We don't need to have teens fail another method before we consider LARC use. And this is absolutely consistent with international recommendations as well. There's a group called Family Planning 2020, as well as the World Health Organization, who recommends these for adolescents. So we're going to take some time to go through the methods one by one. The first one I'm going to talk to you about is the Etonogestrel Implant. This is also called the Nexplanon. I'm not sure if that's what it's called in your location, but in the US it's called Nexplanon. This is a 4-centimeter contraceptive implant. It is 99.95% effective, and it lasts for at least 3 years. It has an FDA approval for 3 years. It is progestin only, so it can be used by women who have contraindications to estrogen. And it's a very quick office-based procedure. I tell people it takes me 5 to 10 seconds to place a Nexplanon. And the benefit of this method is that you really can do something once, and it doesn't require the user to maintain the method to have effectiveness. The most important side effect to talk to potential users about this method is that the bleeding is unpredictable on this method. And that's my favorite word to use because we really don't have a good sense of who will bleed in what way. Most women users who use this will have fewer days of bleeding and lighter days of bleeding than their previous period, but about 1 in 5 have more bleeding. And I've put a citation there on this slide. And there's also a more recent citation from 2019 that's also available. What we have found in these 2 studies, which are analyses of the clinical trials, which is that the bleeding in the first 3 months is broadly predictive of future bleeding for most users. However, bleeding is the primary reason for early discontinuation. So it's very important to counsel women about unpredictable bleeding on the Nexplanon. The Etonogestrel implant does not appear to affect bone density, and women report or have found to have none to very minimal weight gain on the method. Common side effects include longer or shorter periods, no periods, spotting between periods, as well as irregular timing between periods. Other associated side effects include headache, breast tenderness, mood changes, acne, and weight gain. And these are all side effects reported in the clinical trials. The rate of discontinuation among younger users does appear to be similar to older users. So one of the potential criticisms of increasing access for young people to LARC was that they were just going to change their mind and stop the method. And what we have found is that the discontinuation rates are very similar in the first year of use. So that was found in a large study called the Choice Project, which was the continuation rate was 82% at the first year in a study. And then I conducted a study with some colleagues here at Nationwide Children's, and we found that out of our 750 first users of Nexplanon, only 10.3% were documented to have a discontinuation within the first year, which is really consistent with the adult literature as well. And we found that bleeding problems were the primary reason for early discontinuation as well. In terms of non-contraceptive benefits, I think it's important to think about other benefits of contraceptives. The Nexplanon is actually really good for the treatment of menstrual cramps. In the clinical trials, about 80% of women with cramps reported that they have resolved with use of the Nexplanon. In terms of contraindications, there are not very many medical contraindications, but they include unexplained vaginal bleeding, which is suspicious for a serious condition, a pregnancy, of course, as well as lupus with unknown or positive antiphospholipid antibodies. I have grayed out the contraindications that are less common among adolescents, but among all potential users, past or current breast cancer, as well as liver cirrhosis and adenoma, are contraindications to use of Nexplanon. And you can reference the World Health Organization guidelines or the CDC guidelines to get additional information on contraindications to this and all the other hormonal contraceptives we'll talk about. There's also another contraceptive implant that I'm not as familiar with because it's not available in the US, but this is called Jadel. This is a Levonorgestrel implant. And this is actually 2 75 milligram Levonorgestrel embedded rods that are implanted into the upper arm. This method as well is more than 99% effective, and it is effective for 5 years. As well, this is a progestin-only method, and as well has a very simple, quick office-based procedure to insert and remove. It also involves just doing something once, and this one is effective for 5 years again. Side effects as well include irregular periods, which may be common for the first 6 months. All right, so we're going to move on to intrauterine devices. In the US, we have a variety of intrauterine devices, and I'm certain that you have some different ones available where you practice. The Paragard is our copper IUD. It's been available since 1984. And then we have 4 hormonal IUDs, including Mirena, Skyla, Liletta, and Kylena. And we'll talk about those in some detail in the next slides. So hormonal IUD is a small, flexible intrauterine device that releases a progestin. And the progestin that's in hormonal IUDs is Levonorgestrel. These methods are more than 99% effective for the duration of use and approved for use for up to 3 years, 5 years, and 6 years of use in the US. There are other Levonorgestrel IUDs in the world, as you may know, that are approved for use up to 7 years. The hormonal IUD has no effect on bone density or weight, and women may have some cramping and irregular bleeding for the first 3 to 6 months, and that's a really important counseling point. The non-contraceptive benefits include treatment for heavy menstrual bleeding. So Mirena, which is a 52 milligram Levonorgestrel IUD, does have a US FDA indication for treatment of heavy menstrual bleeding. These devices as well are very effective for menstrual cramps or dysmenorrhea, as well as treating women with PCOS to protect their endometrium from uterine hyperplasia. Copper IUD is another LARC method that requires the user to do something once. There are a variety of copper IUDs in the world. The one that we have in the US is called Paragard. This is a small, flexible, hormone-free intrauterine device that's wrapped in copper, and this Paragard is more than 99% effective. It's effective for at least 10 years, and the FDA in the US is for 10 years. And it is also the most effective emergency contraceptive available. About 20% of users may experience heavier periods and increased menstrual cramping, and we found that this is really not a particularly popular choice among adolescents, but there are certainly populations of women who choose this method, including women who have a preference for low to no hormonal effect, or who have medication or medical contraindications to hormones. Contraindications to overall IUD placement include having current pelvic inflammatory disease, purulent cervicitis, a chlamydia or gonorrheal infection. It is not recommended to place an IUD if any of these are present. However, if disease is detected after placement, the recommendation is actually to treat the infection first, and only remove the IUD if the infection is not resolving with standard treatment. Another contraindication for IUD placement is unexplained vaginal bleeding, which is suspicious for serious condition. And then for a hormonal IUD, it's contraindicated for lupus with unknown or positive antiphospholipid antibodies, as well as pregnancy. All right, so I have a couple slides that we call the 5 great IUD myths. And in the work that I and colleagues and associates have been doing in the US, we've really been trying to improve awareness of the intrauterine devices. And we have gotten feedback from our patients as well as the general public around their concerns, and we're going to go through those. So one of the concerns that we hear often is, shouldn't you have had a baby before getting an IUD? And I let people know that IUDs are really safe for women who have never had a baby and never been pregnant. And in particular, in the FDA language, the IUDs no longer have parity in their indication. They have been demonstrated to be safe in nulliparous females, and the contemporary IUDs are not associated with infertility. So these are really a great choice for women who've not been pregnant and not had a baby. It will hurt too much. So I'm sure you may have heard this from potential young users as well as older users. And we place IUDs in adolescents all the time here at Children's Hospital. And what we have found out and what the literature supports is that teenagers and young women really do tolerate IUD insertion very well. We like to screen that at least possibly have had a tampon inserted, or we might try to do a pelvic exam first before the IUD procedure just to assess if they've not been sexually active, how they would tolerate the procedure. But they really generally do very well. And when we ask patients afterwards, and the literature supports this as well, how it compared to their expectations, most of our patients report the pain was less than they anticipated. We offer the use of relaxation, aromatherapy, and distraction, and generally recommend those approaches for women during IUD procedures. And you can also consider the placement under sedation for select users, such as those with a history of sexual trauma, PTSD, anxiety, very young, or maybe women with special health care needs. Also, it's recommended to consider a paracervical block with lidocaine with insertion to reduce pain. So doesn't having an IUD increase the risk of a pelvic infection? So the good news is no. At present, the contemporary IUDs do not have an association with pelvic inflammatory disease. What we have found is the risk of pelvic inflammatory disease is increased for 20 days after the insertion of the IUD. And this is not related to any fault of the IUD, but really related to inserting instruments in through the cervix into the uterine cavity. And also could be due to the presence of an infection prior to insertion. So really recommending just routine screening and screening per protocol for infections, but no long-term risk for pelvic inflammatory disease. And then this one, it's not so prevalent anymore, but at least over the last several years, it seemed like every patient knew someone who had a complication. And I'm gonna, excuse me, just move that. And so I share with people that IUDs are actually far safer than combination hormonal contraceptives. The risk of a perforation is less than 1 in 1,000, and the risk of a serious complication is less than 1%. So LARC, which are the IUDs and implants, are really far safer than combined hormonal contraceptives, and they're far more effective. So a lot of people think, well, teenagers just prefer pills. And that's actually not true as a generality. In a study, which was the CHOICE study, when cost was removed as a barrier, adolescents were actually more likely to pick a LARC method over other methods. As well, one other study found that more than 50% of young women thought positively about IUDs after being educated on them. I don't think that the LARC will ever be probably the most common contraceptive used by adolescents, but I think it's important to know that your patients very well may be interested in them and be great candidates. So what I recommend is that as you're counseling your patients, to really ask them kind of what they have heard about IUDs and implants and what concerns that they have. And this allows you to identify and address their myths and provide accurate information to them. And it also allows you to accurately acknowledge accurate information that they have. So if you're getting some pushback about these concerns, I really encourage you to talk with your patients about their concerns and help them understand the facts. All right, so that concludes our IUD and implant portion. We're going to talk next about contraceptive counseling broadly. And I may speed through a couple of the slides because I want to save time for questions at the end as well. So contraceptive counseling is really something that is recommended to be done by a variety of healthcare providers. So internal medicine, family medicine, pediatrics are all recommended to do contraceptive counseling for women at risk for unintended pregnancy. And a great place to do that is at the annual preventive healthcare visit. We're going to talk about getting started with contraceptive counseling, and I'm going to share with you some specific considerations for that may be helpful for dealing with your adolescent patients. So certainly with adolescents, establishing rapport is very important. So really having established a relationship with them where they trust you, where your presence is warm, and they really understand that you're there to help them. Some special considerations for adolescents include, and this would depend on the local laws in your area, but providing appropriate reassurances around confidentiality if you have confidentiality protections. Checking your biases. So clinicians certainly have biases and preferences around contraceptives. So really kind of putting those to the back and focusing on your patient and your patient's choice is a really important thing to do. It's recommended to avoid discussion of personal experience other than the patient's. So it's not recommended to talk about your own or your partner's contraception use with your patients. And also be aware there may be contraceptives you're less familiar with or that might be less available. It's not recommended to counsel less about those. It's really recommended to counsel kind of equitably among the methods, so your patients have access to all the methods that would be potentially good fits for them. And then kind of down the road, figure out kind of the access if they're less available. All right, so the foundations for contraceptive counseling include, in terms of the medical history, screening for thrombophilia, which is an inherited blood clot disorder, thrombosis in the person themselves, migraine with aura, and then reviewing any other chronic medical conditions that the woman has. And this is really important to determine if there are any contraindications to contraceptive use. In terms of family medical history, you may want to inquire about inherited bleeding disorders in the family, or excuse me, clotting disorders. And one way of doing this is asking about younger immediate family members who have an unexplained blood clot. And then you can really use that information to help understand your patient's risk for blood clots. And then menstrual history, getting the first date of her last menstrual period, possibly the age of menarche for a younger patient, the frequency and duration of her periods, as well as the presence of menstrual cramps and heavy bleeding. The reason to do this is that your contraceptive method is likely to change your bleeding pattern, so it's important to have an assessment documented before starting the method. A complete gynecologic history and obstetric history is important, as well as sexual history, which includes partners, practices, the type of protection that she uses from sexually transmitted infections, past sexually transmitted infections, what she's been using before or previously to prevent pregnancy, and then if she has any history of sexual assault or abuse. And this is particularly important if you're going to be referring or placing an IUD and doing a pelvic exam. It's important to review medications, to review potential medication interactions, and then finally, to assess the patient's priorities and preferences. So identifying patient-centered reproductive goals is really important, and one of the first steps to doing this is assessing pregnancy intention. Even in pediatrics, I counsel the physicians I work with and the trainees I work with to assess pregnancy intention so that you can really align your counseling with the patient's reproductive goals. And there's several ways to do this. You may have heard of this. This is called the one key question. This is a really simple way to assess pregnancy intention in the next year. And it goes like this. Would you like to become pregnant in the next year? This is certainly not the most nuanced or sophisticated way to assess this, but it really helps you know within the next year, does she want to get pregnant, yes or no? Or maybe she's a maybe, and how you can help her with her reproductive goals. There are a series of questions called the PATH questions, which are more nuanced, and I actually really love them. The first part of the PATH questions is, do you think you might like to have children or more children at some point? When do you think that might be? And then how important is it to you to prevent pregnancy until then? These questions are great because they can be used with males. They don't assume that the person themselves could become pregnant. And they really allow you to gauge how important pregnancy prevention is, as well as the timeline for the potential user of a contraceptive. And Patty Kaysen, who's a nurse practitioner, developed these questions. The clarification of the reproductive goals is so important because it really helps you clarify the degree of motivation and acceptability of a pregnancy. And then you can offer appropriate interventions, which may or may not include contraception, preconception care, or even fertility or adoption services. So then kind of checking for understanding. As an example, so you're interested in having kids, but it's important to you to wait a while. Or I get it. You're not interested in having children anytime soon. So really checking to make sure that you understand what she's said, and then offering to extend the conversation. Would you like some information today about how you can prevent an unintended pregnancy is one option, or even, would it be okay with you if we talked about some birth control options? Another question to ask before contraceptive counseling is started is, do you have a sense of what is or might be important to you about your birth control method? Or do you have a sense of what you're looking for in a contraceptive method? And again, these questions aren't necessary, but they will help you understand the patient's priorities and values related to contraceptives. For younger users, they often may not be able to answer these questions well, but older women and people who used contraceptives before certainly may have a sense of what they liked or didn't like in their previous methods. Very importantly, it's important that the patient understands that the decision to start and stop a contraceptive is hers to make, and that the decision for contraception use is freely made. So we want to avoid any sense of coercion, and we want to make sure that the patient has freely consented to the use of a contraceptive method. And here's an example of this wording. I'm here to help you decide which birth control method is right for you. What's right for you may be different than what's right for your mother, your sisters, and cousins, or your friends. The decision about starting or stopping a method is yours to make. So again, just some examples about language in communicating with your patients. The recommended type of decision support right now around contraceptives is called shared decision making. Directive counseling would be the clinician saying, I know what the right method is for you, and it's X method. Informed choice is really the patient reviewing a list and selecting a method. Shared decision making is an approach in which the clinician can really personalize contraceptive choice based on the patient's preferences and priorities, but allows you also to support her decision making to end with a decision that may be best aligned with her preferences and medical history. Alrighty, so the current modality for contraceptive counseling that's recommended is called effectiveness-based counseling. Some people call this tiered counseling. This involves providing a brief information about the contraceptives from highest to lowest efficacy with typical use. And this is recommended by a variety of societies, including the World Health Organization. Another approach is to discuss and educate, in particular, about preferred methods. But you do want to make sure that the patient has the opportunity to learn about all the methods that she's interested in, and that might be available to her. So this is an example of a tiered effectiveness counseling tool. This is available at the website on the slide. It's bedsider.org, and it's a really nice, very patient-friendly tool that you can get printed out as a PDF, or you can get for your wall in your office, that helps a woman understand how effective the methods are. And this is an example that you might be more familiar with. This is the World Health Organization contraceptive efficacy chart, and is also available for use in contraceptive counseling. In terms of starting a method, the most important things to do in terms of medical decision making are, number one, being reasonably certain she's not pregnant, and then reviewing the contraindications to make sure there are no medication or medical history contraindications to the method. In terms of being reasonably certain a woman isn't pregnant, you can be reasonably certain that a woman is not pregnant if she has no signs or symptoms of pregnancy and has any of the following present. She can be within or equal to 7 days after the start of her normal period, if she's not had sexual intercourse since the start of her last normal period, if she's been correctly and consistently using a reliable method of contraception, if she's within a week after spontaneous or induced abortion, is within 4 weeks postpartum, or is fully or nearly fully breastfeeding. If a patient meets any of these criteria, then you can be reasonably certain that she's not pregnant. In addition, if you add a negative pregnancy test to these criteria, the negative predictive value is more than 99%, and the citation is there on the slide. So you may or may not have access to urine pregnancy tests in your clinical setting, and you can certainly feel very comfortable using this CDC and World Health Organization guidance. This allows us to start a contraceptive and a date that's not during a woman's menstrual cycle, and improves access and adherence to the use of the contraceptive method. All right, so if you have access to apps, the Centers for Disease Control app is very useful. You can search in the app in the Google Play or in the Apple App Store under CDC and contraception, and you can see that there is an area of how to be certain a woman is not pregnant. So for your reference, you can use that there. All right. So in terms of reviewing contraindications, what are the good resources for this? So the one I'd recommend that we use here all the time is the U.S. medical eligibility criteria from the CDC, which is derived from the World Health Organization source. So that's the CDC medical eligibility criteria. And again, if you have downloaded the app, you can see that you can search by condition or method, and then you can look by method or condition and review medical contraindications to use of a method. As well, if you do not have access to cell phone apps and have access to the internet, you can go online to the CDC website and search medical eligibility criteria, and you can download these really handy handouts and wall hangings, or the complete text guidance. So definitely recommend that you do that if you haven't already. In terms of the provision of contraception, what is ideal? Really, the ideal approach is to provide the method of choice at that visit. Again, that involves screening the patient's preferences, providing shared decision-making, being reasonably certain she's not pregnant, and reviewing medical contraindications. However, if you're unable to provide at the method, at the visit, there are really some recommended options. So one of the recommendations is to schedule for a return visit as soon as possible to your clinic if it was just that you didn't have time at the visit. Another approach would be to refer to another clinician who can provide either the counseling or the method of choice, and that can be another clinician in your specialty or a different specialty. And then also to consider providing a bridging contraceptive method. So this would include, for example, if she wanted a hormonal IUD and you did not provide that, could you provide a depot shot or a mini pill or an oral contraceptive to the patient while she is waiting for her appointment for her IUD insertion? All right, so in summary, thank you for your patience. Your patient's made a decision. You are reasonably certain she's not pregnant, and there are no contraindications to the chosen method. And so you provide the chosen method, or she returns later, or is referred to a contraceptive provider with consideration of a bridging method. So here are some resources, and I will send this slide to the administrators of the Grand Rounds talk, and if you're interested, you can certainly get a PDF of the talk with all of these resources. And then here's just an initial article about provider bias that was published in the US recently that I thought was very, very good. So there you go. Here's my email. Please feel free to contact me if you need anything. There's my Twitter handle. And I just want to acknowledge the support of my mother and my husband and my kids, who really let me do all the work that I do and provide support. So that is the end of my talk, and I'd love to get any questions and comments that you have.
Thank you so much, Elise. This was excellent. This was very good. And I love the picture, by the way. I have an 18-month-old too, so and the kids are adorable. All right, let's open it up. This was an excellent talk. Let's see if there are any questions. Albert and others, if there are any questions, this is a good time to ask Dr. Berlan. Okay, so I think at least they don't have any questions right now, but
okay.
I just got a WhatsApp message that they love this,
Oh, great.
And messages, and they said that they would like to send you some questions by email, if that is
for
fine.
Sure. That's absolutely possible. I'll respond.
Okay, and I also got another message saying that this is really important in their country, and this talk is extremely helpful because they are trying to promote the use of contraception, but there are some taboos which they face, and they're going to use the learning from this talk to help their patients.
Wonderful.
Yeah, so this was excellent, and this was so well done. I really appreciate you doing this for us.
Oh, it's my pleasure. Thank you so much for the invitation. I'd love to do it again or
Thank you so
on
much.
Another topic. And I will send the PDF of the slides to the staff. And if there's any way to share that with folks, I'd be happy for that to be shared.
Yeah.
All right. Take care.
Yeah. Okay. Sounds
okay.
good. And I